Welcome to the next part of this video session of our conversation with prominent neurosurgeon Dr. Pankaj Maheshwari. Welcome back.
Thank you.
When a patient comes to you with a diagnosed cancer and now you decide that it's time, it is because of the grade or because of the intensity of growth, you would want an operation to be done. What are the, you talked very highly about the robot, but if the robo is not available and if there are there other surgical options that you said were prevalent a few years back? So what is that option and how does it compare? We're not comparing apple and oranges, but then I think the patient would like to know if they're going to go for a robo and what was the other option that was available and why should they go for the robo?
Okay, so again, a very important question, and this is something we should discuss. So, as I've said, 10 years back, we had only one option, that was open operation. Open operation was extremely difficult for the patient as well as for the surgeon. The site where I had to operate was very deep inside. Reaching there was difficult. There was a significant risk of needing blood transfusion, and almost all patients became impotent after open surgery. Over last 5-7 years, laparoscopy came in. So with laparoscopy, it would be possible to remove the prostate. But laparoscopic radical prostatectomy is the name of the surgery for cancer prostate. Laparoscopic radical prostatectomy is a technically very challenging procedure, and not many people will be able to do a very good job with laparoscopy.
Good means a complete job.
Complete job. Okay. And robotic makes it very simple for the patient as well as for the surgeon. I would tell you the first robotic surgery we did for cancer prostate, and you were definitely part of that surgery, was, if you remember, we had a senior doctor in whom we had operated, and this was done around 3 years back. The surgery got over evening 6 and next day morning 7 patient was walking. This is impossible when you do laparoscopy or open operation. The patient may be ready to go home in 3 to 5 days. The side effects of radical prostatectomy, loss of control of urine, loss of sexual function, and a need for blood transfusion. All three are significantly less with robotic as compared to laparoscopy or open surgery. Yes, robotic entails slightly higher expense. Okay, the robotic equipment would increase the cost by around 1.2 lakh rupees. But that gets compensated by reduced hospitalization, reduced need for medicine, and a much more smoother post-operative course.
Fantastic. As an anesthetist, I cannot agree more because जो भी हमारे पेशेंट्स ज़्यादातर प्रोस्टेट का तो वो सभी लोग एल्डरलीज रहते हैं 60+ और जैसे कि आप सब जानते हैं कि जितना उम्र बढ़ता है उतना हाइपरटेंशन, डायबिटीज़, हार्ट फंक्शंस की प्रॉब्लम्स आते हैं और ये सभी इसमें एज एनेस्थेटिस्ट जब हम लोग पेशेंट को देखते हैं तो हम लोग भी चाहते हैं कि पेशेंट को ऐसा ऑप्शन मिले जिससे कि कम से कम ट्रांसग्रेस या एग्रेशन के साथ वो प्रॉब्लम को सॉल्व किया जाए और जल्द से जल्द रिकवरी भी हो जाए बिकॉज ओपन सर्जरी में पेन, पोस्ट ऑपरेटिव पेन और बाकी प्रॉब्लम जैसे सर ने बताया वो ज़्यादा रहते हैं और रोबोटिक सर्जरीज़ में जैसे अभी तो हमारे सर्जरीज मेरे ख्याल से 4 से 5 घंटे 6 घंटे में हो जाते हैं और कभी कभी हमने दिन में 2 सर्जरीज भी करते हैं शाम तक और ये सभी पेशेंट्स ऑपरेशन के बाद ऐसे देखने में यकीन नहीं होता कि इनका कल एक दिन पहले मेजर सर्जरी हुआ था जिसको हम लोग शायद पुराने दिनों में उनको 2 दिन के बाद आईसीयू में से निकालते थे। ये जो रेडिकल शिफ्ट हुआ है वो इस कारण हुआ है कि नंबर 1 डिटेक्शन जल्दी होता है because of work that the urology and the urology society is doing to identify the cancer और दूसरा हमारे पास एक ऑप्शन है टू प्रोवाइड मिनिमम एक्सेस जैसे हम लोग को वॉर में जैसे कहते हैं कि हम लोग ने सर्जिकल स्ट्राइक किया उसी तरह की सर्जरीज डॉक्टर महेश्वरी करते हैं कि गो टू द विदाउट डिस्टर्बिंग एनीथिंग एल्स आप सीधा प्रोस्टेट के पास पहुंचते हो और जितना काम करना उतना करके आप निकल जाते हैं और बाकी सभी चीज़ें जैसे आपने बताया कि सब फंक्शंस प्रिजर्व रखते हुए बाकी के इम्पोर्टेंट ऑर्गन्स को डैमेज न करते हुए हम लोग को एक सवाल है कि सर क्या हर कोई पेशेंट जिसका डायग्नोसिस प्रोस्टेट कैंसर जो सर्जिकल कैंडिडेट है अभी सभी का रोबोटिक सर्जरी कर सकते हैं कि किसी का हम लोग नहीं कर पाएंगे ऐसे कुछ है?
देखिए, रोबोटिक सर्जरी करने की एक बेसिक रिक्वायरमेंट ये है दैट कि बीमारी प्रोस्टेट के अंदर ही चाहिए। अगर बीमारी दुर्भाग्य से प्रोस्टेट के बाहर चली गई है या बीमारी कहीं फैल गई है उसमें रोबोटिक सर्जरी का कोई रोल नहीं है। सो अगर प्रोस्टेट और प्रोस्टेट के आसपास के ऑर्गन्स जैसे होते हैं, जैसे सेमिनल वेसिकल होता है या प्रोस्टेट के आसपास की जो लिम्फ नोड्स होते हैं, अगर उसमें बीमारी है तो इनमें ट्रीटमेंट हार्मोन्स और रेडिएशन से की जाती है। अगर बीमारी फैल गई है कि हड्डियों में चली गई है, शरीर में बाकी जगह चली गई है, ऐसे में भी अगेन हार्मोन और कीमोथेरेपी के कॉम्बिनेशन से ट्रीटमेंट होती है। अगेन हम फिर से वो पहली वाली बात पर आएंगे कि कोई और कैंसर अगर शरीर में फैला हुआ है तो उसमें हम बात करते हैं लाइफ की कुछ महीने, पर प्रोस्टेट कैंसर अगर शरीर में फैला हुआ है तो भी काफ़ी पेशेंट में 3 to 5 years लाइफ एक्सपेक्टेंसी होती है। सो इम्पॉर्टेंट ये है कि अगर आपका फैला हुआ कैंसर है तो भी ट्रीटमेंट कीजिए। ट्रीटमेंट बहुत ज़्यादा रिस्की ट्रीटमेंट नहीं है, ट्रीटमेंट बहुत महंगी नहीं है। एक छोटा ऑपरेशन करके दोनों अंडकोश निकालते हैं, एक गोली रोज लेनी होती है, शायद कुछ रेडिएशन की ज़रूरत पड़ सकती है, और जहाँ जहाँ कैंसर है अपने आप श्रिंक हो जाता है। कई बार हम इसको पेशेंट्स को कैसे एक्सप्लेन करते हैं कि भाई चलिए आपसे कहा गया है कि बाजू के कमरे में एक लायन है जिसको आपको मारना है। जरूरी नहीं कि आप जाके वो लायन से कुश्ती लड़ना शुरू कर दें, आप उसका दरवाजा बंद कर दो, उसका खाना पीना बंद कर दो, वो अपने आप हो जाएगा। ठीक है, सो ये शरीर में हमारे एक लायन आ गया है जिसको हमको उसको बाहर निकालना है। ये बीमारी बढ़ती है मेल हार्मोन से, तो अगर हम शरीर से मेल हार्मोन निकाल दें तो जहाँ जहाँ ये बीमारी है अपने आप श्रिंक हो जाएगी,
कंट्रोल में आ जाएगी।
कंट्रोल में आ जाएगी।
ओके, ये हार्मोन थेरेपी बहुत महंगी है, एक्सपेंसिव है, या इसका अवेलेबिलिटी कैसे किस तरह से?
नहीं, रादर ये काफ़ी चीप इसमें भी हो सकता है कि एक छोटा ऑपरेशन करके दोनों अंडकोश निकाल देते हैं। अगर अंडकोश निकाल दे, टेस्टिस रिमूव कर दे, तो हार्मोन्स बनना ही बंद हो जाएंगे और इट्स अ वन टाइम ट्रीटमेंट एंड वेरी गुड रिजल्ट। हाँ, आप ऑपरेशन नहीं चाहते उसके लिए कुछ इंजेक्शन है, वो इंजेक्शन थोड़े महंगे बट नॉट एक्सॉर्बिटेंट, मीन्स इट विल एंटेल अ कॉस्ट ऑफ मे बी अराउंड 7 to 10,000 rupees per month and that should take care by injection also. In long run the results of injection and surgery are same, but you see lot of patients may feel कि हमें बार बार अस्पताल नहीं आना है, एक बार निकाल दो। some patients में से कि नहीं मुझे ऑपरेशन नहीं कराना है, आप तो इंजेक्शन दो। so ये डिसीजन हम पेशेंट से डिस्कस करके लेते हैं डिपेंडिंग ऑन व्हाट ही वांट्स।
Excellent. So it is clear now that it is not one treatment fits all. Every patient will be analyzed and based upon the management protocol, he will be put on a path to recovery.
Absolutely.
Or to control or to surveillance of the disease. Perfect. So I think now that our audience may be convinced that yeah, we have to go for the test and for the PSA test and the clinical exam. I just wanted to ask whether only the clinical test, obviously you said that it might not have been grown, or all grown prostates may not have prostate, may not have cancer. And secondly, are these two tests to be done, are these two things to be done together to have a higher sensitivity, specificity for the cancer? Is it like that, or anybody with a high PSA we could say he's got cancer?
No, good, wonderful question. You see, understand that PSA stands for prostate specific antigen. It is not cancer specific.
Correct.
It is prostate specific. So lot of diseases of prostate will have raised PSA. So if somebody has infection, somebody has a very large prostate, somebody has retention of urine, somebody has some instrumentation, all these can raise PSA. Okay. So that is why you do a blood test PSA and you do also clinical examination. If there is still a doubt whether patient still has cancer or not, then the next thing to be done is a MRI. Okay. MRI gives us a score which is called as a PIRAD score, which will help us pick up patients who are likely to have significant cancer. Now, so this is also one more very important word we should discuss here, that prostate cancer is one cancer where we divide the cancer into significant and not significant. So significant is something which is likely to trouble me in my remaining lifetime. Non-significant is something which is not going to kill me, rather I will die with the cancer, not because of cancer. So my aim is to diagnose only significant cancers. So if clinically I don't feel a cancer, then I do a MRI. If MRI shows high score, high PIRAD score, then it is likely to be significant cancer and then we do biopsy. If MRI shows low PIRAD score, patient is likely to have a non-significant cancer. In those situations, you don't even do biopsy. Unnecessarily, why increase the stress of patient by giving him a diagnosis of cancer? You just leave him and keep him on follow-up.
So do you, in your whole cohort, there are, I would like to ask, what is the percentage of patients who are on this kind of surveillance or who come for a low grade tumor which is to be monitored rather than
You see,
addressed?
if we see 10 prostate cancers today, then out of 10, bad luckily, at least 5 or 6 come with advanced disease.
Oh, okay.
Okay, because even today, the regular checkup is not done by many patients. So they come when the disease is already spread. So at least 50% come with advanced disease. So they definitely need hormone therapy and chemotherapy or some form of treatment in that form. Around 20%, 30% are localized who get treated by robotic surgery or by radiation. And around 20% go on active surveillance.
Okay. So I think all of us have to come together to change the statistic. We
True.
should be having at least maybe 8 to 9 out of 10 who would come in the right time, and that is, I think, even if that happens, this conversation and this time that we've taken would be worthwhile, I guess. So I think one of the important things is that you told is that surgery is not the only option, and you said based upon the grade and the intensity and the age and a lot of other factors you decide about the surgical treatment as such. The people would also like to know, I think, if is there a genetic predisposition for this? Like, is that if your father or grandfather had, because we can very well understand that at that time the detection potential was low, and it is going to happen for vast majority of patients. So if somebody had predisposition, is there a predisposition of this cancer?
Yes, definitely. So, like many cancers in our body, even prostate cancer is genetically monitored. Okay. In a lot of patients, we would be doing genetic tests to decide what the further course of treatment will be. By genetic test, I would be able to identify a patient who is likely to progress in future. So maybe then I would not put the patient on active surveillance and get more aggressive in him. Genetic test also helps us do what is called as precision medicine. Means we can choose the drugs which are likely to be effective for that particular patient. So genetics plays a very big role in this treatment. And yes, as we have said, if your father, uncle, maternal uncle, or even your aunts had breast cancer or ovarian cancer, you have a higher risk of cancer, and in you the early surveillance or early checkup becomes very important.
So that's another interesting thing, that this genetic typing to help us determine the possible course and the therapy that we should put. Is it done after the biopsy, or how does it?
So there are few blood tests available. There are few tests on the biopsy as well.
Okay.
Okay. So once the patient comes, based on what his situation is, we take a call.
Okay. So other thing, the cancer recurrence is a big theme in most other cancers. So what is your experience in prostate cancer? We understand it's a slow growing tumor, and you said that often we do not do anything and just do on surveillance. So is there risk of cancer or a tumor recurrence in prostate cancer?
So tumor recurrence is possible. It is more likely if the patient comes with a large local growth or a high grade cancer. Okay. If it's a low grade cancer and an intraprostatic cancer, then once I remove the prostate, the possibility of it coming after many years is very low. But if it was already outside, or when we removed it, we have gone through the cancer and probably left behind some cancer, in those patients the recurrence is possible. So it is possible to predict in which patients it is likely to recur. And those patients we keep on more aggressive follow-up. Yes, once you develop a cancer, regular checkup is very important. You will still need to keep on doing a PSA regularly.
Yes.
We will try to watch when the PSA starts rising again. If the PSA starts rising again, then we will start looking for whether there is any recurrence or metastasis.
Correct. The other question I think that you've probably been asked and be likely to be asked is the surgery the end point? Like, when the surgery is done and we're not talking recurrence now, that is it? Or like other cancers, they have other therapies which have to be immediately started once the biopsies of
So
the tumors.
again, if it's a localized disease, as I've said, intraprostatic cancer, not a very high grade cancer. Post surgery, you do nothing but keep on doing PSA at regular intervals. If it is extraprostatic on your histopathology report, then you may add radiation or hormone therapy for that patient.
So if the tumor, just to understand better, if the tumor has gone beyond the capsule or it's advanced, there is no role of surgery as such because of the gland.
So in a locally advanced cancer, ideally we would want to do radiation and hormone therapy. But sometimes this locally advanced disease comes as a surprise on histopathology.
Okay.
So what prostate I remove, I send it for pathology examination, and the pathologist tells me that okay, it has gone out. In these patients, I may add radiation or hormone therapy.
But in today's world, with the kind of high grade investigations, it is less likely that it is possible. So, in your practice, daily practice, are there any myths that you would like to bust in general about prostate cancer? Because in our country, especially, we are very secretive about these kind of things, and many people wouldn't like to discuss it with other people. I do not know if there's a prostate cancer support group and such organizations which exist, which will help the patient to understand better. So you are the person they come and visit and tell their fears. So just if you could enumerate a few fears that you think should never be there in anybody, any person with the prostate, would you like to enumerate those?
Yes. So remember that it is not necessarily a disease of old age. It can happen at a younger age. It is important to do a regular checkup. Without that, you will not be able to identify it in right time. If it is identified in right time, a lot of patients do not need surgery, can just be observed. If it is identified in right time, it is completely curable. If it is identified in right time, we will be able to, in most situations, preserve your sexual function and your control of urine.
Okay.
So finally, it all boils down to diagnosing the disease in the right time.
Yes.
And this will be done by a regular checkup.
So I think there are a lot of benefits of identifying the disease early. And in the quest for a perfect health, we should not neglect any symptoms that may come. And unfortunately, like Dr. Maheshwari mentioned, the symptoms may not be there for this tumor. At the same time, it is something that we need to aggressively pursue and diagnose. Visiting a urologist and getting a PSA done are only the starting points, and doing them regularly probably would be a great distance. Okay, so one question, sir, because I think a vast majority of patients will be the one with benign prostate hyperplasia, which is the most common male-related problem that patients are visiting you with, and you treat them very well with holonium laser surgery in a very quick time with under regional anesthesia most of the times, and even patients with heart disease and drugs can address it. So the complication that we used to see about that prostate compressing and causing renal problems or kidney problems are probably going on the decline. How often do these benign BPH, we call them, or benign prostate hyperplasia, or the non-cancer prostate problem progress to cancer? How often does it happen?
This is one myth which most patients have.
Okay.
And I'm so happy you have asked this question. Understand that cancer prostate and age-related prostate are two different diseases.
Okay.
They happen in two different zones of prostate.
Okay.
So they can coexist, but one does not get converted to other. Okay. So if I have prostate enlargement, my risk of cancer does not increase. My risk of cancer remains what it is. If I get treated for prostate enlargement, my risk of cancer remains as it is. So if I do laser surgery, that doesn't mean that I am protected for cancer. Yes. And because these are two separate diseases. Before we sign off, Vijay, there are few more things I would want to tell the patients how to maintain their prostate health in the best possible way. Okay. Now, as we have said, because prostate plays a role in along the passage of urine, so it is important that patient should not overdrink or underdrink liquids. It should be an optimum fluid intake. Do not try to hold urine for a long time. Go for urination whenever you get a sensation. Try and avoid constipation. Constipation distends the rectum and reduces the bladder contractility. Two more important things is regular exercise is very important. It is said that even if a person can do 30 minutes of high intensity exercise, the risk of prostate cancer reduces substantially. So even at a senior age, having regular exercise is important. If you cannot do high intensity, do routine exercise, but exercise is important. And most importantly, remember that cigarette and health don't go together. Cigarette smoking is one of the most important cause for many cancers all over body, also prostate cancer. So if we can take these precautions, the possibility of us developing major diseases in the urinary system will dramatically reduce.
Fantastic. I think as a take home, a lot of important tips have been given to maintain the health, and these we need to implement as soon as possible, even at a very young age. I think Dr. Pankaj Maheshwari, thank you very much for being with us today.
Vijay, and it has been a pleasure talking to you.
And we learned a lot of things. I learned a lot of things on the way as well. And if still there are some concerns or unanswered questions, please write on the comment section, and our team will get back to you and try to solve them as early as possible. Thank you, and look forward to seeing you again.
Thank you.